Welcome everyone to our second webinar of our Winter-Spring webinar series brought to you by Leukaemia and Blood Cancer New Zealand here in 2020. We are joined today by Tracy King. She is a myeloma clinical nurse consultant at the Royal Prince Alfred Hospital in New South Wales. And she has been for decades, as she has told me already. She has a particular interest in myeloma and how the treatment affects you as a person. She cares for people with myeloma as well as teaching other clinicians about this area of patient care. She was awarded the Outstanding Research Achievement Nursing and Midwifery Award in 2019 by Sydney Local Health Network for her leadership and research in better understanding the experiences of those affected by myeloma taking high-dose steroids and the role of patient-reported outcome measures. And so Tracy's here for you. We're really grateful and humbled and honored to have you with us, Tracy. And we'll hand the time over to you.
Thanks, Tim, and hello to everybody. It's very odd to be sitting in my office, talking to my computer, not knowing and seeing your wonderful faces. I do enjoy coming over to New Zealand to participate in these meetings. So what I've done today is to prepare a set of slides to talk about managing side effects of treatment. As Tim said, I spend my working day with patients with myeloma and spend about probably 80% of my time talking to patients about how to manage side effects. So I have a lot of slides today, and I do know this will be available to you afterwards on the YouTube channel, but I'm also very happy for New Zealand team there to send you a copy of my slides. And if you want to contact them afterwards, they'll arrange to send you a copy. So please don't worry if you don't get to all of the content on my slides and you have time to go back and review. But anyway, and I've also just remembered, I spent last night dreaming about donkeys. And I woke up this morning thinking, why on earth am I dreaming about donkeys? And then I've just realized I was doing my slides late last night. And this donkey on the picture here is, hopefully you're not all feeling like donkeys, helps explain my dream. Do you think we could talk about the side effects of the medication now? So I hope you're not feeling like donkeys, but let's work our way through these slides now. So what we're going to talk about, we'll mention what myeloma is. I'm sure all of you listening to this have an understanding of that because you're living with myeloma. And we'll concentrate on some of the common side effects. Lowered blood counts and infections are common with most treatments for myeloma and are arguably the most common side effects and consequences of myeloma and its treatment. But we're also going to talk about peripheral neuropathy and side effects associated with steroids. We'll talk about how we manage these side effects and how you can manage those side effects, and we'll leave plenty of time for questions. So what we're talking about today is this disease of multiple myeloma. It's a cancer of the bone marrow plasma cells and is characterized by a bony disease, kidney and immune impairment. And I mention that because when we talk about a particular topic, such as side effects, we can't talk about that out of the context of the disease as well, because side effects don't occur in isolation, I'm sure you're aware. We also know that myeloma affects predominantly an older person. Saying that, in our practice, we certainly do have people in their 30s and 40s with myeloma. But with that older age comes a range of other potential health conditions that can impact side effects and how we live with myeloma. We know that we don't have a cure for myeloma at the minute, and so our focus in treating myeloma is about controlling the disease and keeping people well for as long as possible. But a big focus of our care is to minimize the disease and treatment-related effects to maximize your health-related quality of life. And so we do spend a lot of our time as doctors and nurses in myeloma focusing on those aspects of care. We know also increasingly that managing myeloma, and I'm sure all of you out there are very understanding of this, requires a range of treatments over a number of years. So being on treatment for your myeloma is something that can go on for a long period of time, although there are likely some of you out there that have treatment-free intervals also. So I'm not going to focus on the treatments for myeloma other than to mention the range of drugs that we use. And I do encourage you all to come back and listen to Professor Andrew Spencer on the 28th of August, who is going to talk about the treatments for myeloma. But on the left-hand side of this slide are a range of medications and drugs that we more commonly use to treat myeloma. Those of the immune modulators, such as thalidomide and lenalidomide, also pomalidomide coming through, the proteasome inhibitors, bortezomib and carfilzomib. We certainly still use a lot of chemotherapy. We certainly use a lot of steroids with all of the treatments combinations. And on top of that, we use a range of other medications as supportive measures, such as antibiotics, antivirals, painkillers, etc. So a lot of drugs are used to treat myeloma effectively. A range of other new drugs are coming through, and I've listed some of those there, but do come back and listen to Andrew Spencer, who's going to discuss more about these. Also just worth mentioning that with the medications, there are often a couple of different names. I've tried to be clear as I go through this slide set, but for example, lenalidomide is the generic name and Revlimid is the trade name. It's the same drug, and I've tried to be consistent throughout, but don't hopefully not confuse you too much. So we have a large cocktail of drugs to treat myeloma, but they do have consequences. So when we talk about myeloma, we talk often, and it's worth reminding ourselves that this is the myeloma cell. It's a plasma cell that lives and grows in the bone marrow, and its normal job is to produce antibodies that look like this, also called immunoglobulins, to help us fight infection. So when we have myeloma, we have too many of these plasma cells. We might now call them myeloma cells in the bone marrow, overcrowding the bone marrow, and we have too much of this antibody, which is ineffectual, and that may be made up of light chains, heavy chains, or a whole molecule, and we often call that the M protein or paraprotein. And these plasma cells or myeloma cells and this abnormal protein give rise to the main complications and health impact for this disease, in that it can affect the blood and immune system because it is a cancer of the blood and the immune system. These extra proteins can get clogged up in the kidneys and cause kidney damage. Also, they can cause damage to the nervous system, giving rise to peripheral neuropathy. They can impact and weaken bone, giving rise to bone disease and bone pain. And also, of course, the psychological impact of having a cancer diagnosis and its effect on you and your family. And I think this is covered in some other lectures given by the Leukemia and Blood Cancer group. But what we're going to focus on today, and there is some overlap in these areas, are when we start to give you medications to treat this blood cancer myeloma, they also have some very common predictable side effects that we need to focus on managing. And key to that is making sure you guys are all aware of those so that we can have an active and successful conversation about how to manage these. So let's focus now on these particular side effects. We've seen the donkey of my dreams. I'm sure that's a familiar a thought to many of you in terms of you come to see your doctor and you have a range of different side effects you want to talk about, and with the clinician also it's about finding a common language to talk about that. But many of my patients also say to me, look, you've given me 2 drugs to treat my myeloma, but I've got 10 prescriptions. Why am I taking so many medications? And that's because although there might be 2 or 3 treatments that actively kill the myeloma cells, there's a range of other medications that are important to prevent many of the side effects that may go aside with that. So when we talk about treatment side effects, we know that medications and drugs can cause a range of side effects. There are consequences to taking therapy that is aiming at killing the bad myeloma cells in the body. But often these side effects can be somewhat predictable and hopefully manageable. They do also vary in intensity and duration between people. So whilst we talk about these side effects relating to these drugs, not all people get all side effects, okay? But it's important, and we tend to focus on what some of the more common side effects are. And at the end, if anybody has any side effects that are perhaps less common, we'll have a conversation about that as well. Side effects are also very individual because human beings are very individual. Somebody that comes to a diagnosis of myeloma at the age of 40, who may not have any pre-existing health conditions, may experience the different set of side effects with the same treatment as somebody that comes to a diagnosis of myeloma later in life. And by that, I mean, if you had a pre-existing high blood pressure and then we treat you with steroids for myeloma, that high blood pressure may get worse. Whereas if you didn't have high blood pressure, those steroids may not cause a problem with your blood pressure at all. So it's very, very individual. We do know that if we don't focus on managing side effects, it makes it very hard for you guys to stay on treatment. And we know that drugs only work when you take them. So if we don't manage side effects, it can mean poorer outcomes for you guys because you can't manage the treatments that are managing the underlying myeloma. Okay, so response rates can be improved by successfully managing side effects. And that's very much a balance, isn't it? Balancing the potential and actual side effects versus the benefits of the medications in the first instance in terms of keeping your myeloma under control. What I can say is when a key part to managing side effects is understanding what you're experiencing and being able to make those dose and scheduling adjustments, because less can be more. If we know what those side effects are and we can make those adjustments, we can keep you on treatment for longer. So the side effects I'm going to focus on are lowered blood counts and infections, which many of you will be very expert in managing, but it's very important because these are the most common side effects of treatment. But then we'll talk about peripheral neuropathy and steroid effects. As I mentioned, you're going to have these slides. If I chop over them quite quickly, I do apologize, but you can go back and review and read those in your own time at your leisure. So lowered blood counts, we often call that cytopenia, lowered cell counts or myelosuppression are common in all blood cancers and particularly in myeloma. Because of the myeloma, but more commonly because of the drugs we give you to treat the myeloma. Whilst the drugs are lowering the myeloma cells in the body, which is therapeutic and good, there is a bit of collateral damage. And some of the healthy blood cells also do get damaged and the counts become low. In this slide, I've showed you the more common cell types that we are focusing on. Your hemoglobin level, the common ranges are listed there for you. These are important cells in combination with red cells that have a role in carrying oxygen and provide you energy. When your hemoglobin levels are very low, we call this anemia. And this can give rise to symptoms such as shortness of breath, particularly on mild exertion, not necessarily if you're just sitting in a chair. It can also be a very common reason for people to feel very fatigued, and it can also give heart palpitations. You can feel your heart racing in your chest, and that would be a symptom of a severe anemia. The white cells and the neutrophils, which are a type of white cell, are also commonly lowered as an effect of the treatment for myeloma. These cells are very important in part of the immune system and important in protecting us all against infections. A consequence of lowered white cell count, therefore, is increased risk of infections or severity of those infections. And I'm sure those of you that have been living with myeloma for some time are told quite frequently about the importance of monitoring for symptoms of signs of infection, such as feeling hot and sweaty or cold and shivery, maybe having some respiratory symptoms, a cough, a sore throat, or redness and inflammation at the site of an injury or a line or something like that. Okay, and these are very important to be aware of. The normal ranges for these counts are here. The third cell that we focus on commonly are the platelets. Platelets play a big part in helping your blood to clot, and these are commonly lowered, particularly with drugs such as bortezomib, which is Velcade. And that's why we monitor your blood very carefully. If your platelets are particularly low, then symptoms of that would be increased risk of bleeding, perhaps nosebleeds or bruising, or you may notice some bruising or a particular type of rash called a petechiae rash, a redness in dots on the skin, and that would be a symptom of lowered platelets. So when you have a blood cancer, it's very common for us to be monitoring the blood quite closely, and that's why you have a lot of blood tests. So we can watch out for these consequences of the treatment we're giving you, and paired up with the symptoms you may experience, come up with a management plan. So the myeloma itself can certainly play a part in lowering blood counts, because blood is manufactured in the bone marrow, and that's where your myeloma cells live. So when your myeloma is particularly active, it can overcrowd the bone marrow, and therefore it's not making enough healthy blood cells. But treatment for myeloma, as mentioned, the lenalidomide or Revlimid drug, and the bortezomib, which is Velcade drug, and the chemotherapy drugs that you take, also cause these healthy blood cells to sometimes die off or not be manufactured quick enough, and therefore your blood counts are very low. If any of you are having radiation treatment, particularly to the pelvis or the back, that can also impact the capacity of your bone marrow to make healthy blood cells, and all be a reason why your blood counts might be low. There are particular times when blood counts would be more likely to be low. For those of you that are taking higher doses and combinations of treatment, such as a chemotherapy plus a steroid plus a Velcade or a Revlimid drug, that's a particular time when you're at more risk of having lowered blood counts. If you've had lots of treatments in the past, it also means your blood counts may be lower. We sometimes keep extra care and attention to people when they're starting a new line of treatment, and you may be required to take some extra blood tests as you start a new course of treatment. This is because we're not sure as to how your blood counts may be affected. So in our practice, if we start somebody on a new line of treatment, we commonly ask them to come back for a couple of extra blood tests, because in the first few cycles of treatment, this may be a particular concern. Those of you that have had a high-dose therapy and stem cell transplant will know that your blood counts are very low as you go through the transplant, and can take a while to recover afterwards. If I was thinking of the drug most commonly causing lowered blood counts, particularly the white cells, I would think lenalidomide, which is Revlimid, and pomalidomide particularly cause lowered white cell counts, and bortezomib or carfilzomib are particularly known to target the platelets, and the platelets may be lower with those two drugs. How do we manage lowered blood counts? One of the important things is to monitor the blood very carefully. Sometimes we do need to make some dose reductions. We may give you an extra week off, or we may lower the dose of the medication that you're taking, and we have clear guidelines to guide your doctors and nurses in that regard. We do need to make sure that you guys know what the symptoms are. Do you know the symptoms of low platelets, bruising and bleeding? Do you know the symptoms of being very anemic, the shortness of breath and the fatigue? You need to be able to know those so that you can report them to your doctors and nurses when you attend for treatment. How we manage these lowered blood counts, commonly we give you a top-up of the part of the blood that is missing. So when we manage anemia, if it's particularly low, you may need a blood transfusion. There is a growth factor for red cells called erythropoietin that we are able to access if your kidneys are not working well. And the reason for that is your kidneys actually make this erythropoietin. It's a natural hormone, growth factor that you produce yourself. And if your kidneys aren't working great, you may need to have this erythropoietin to help prevent the anemia. If your platelets are low, we give you a bag of platelets. If your white cells are low, we do have a growth factor for that. And some of you may have had that GCSF injection, small injection under the skin in the tummy to boost the white cells. So we give you those counts back, or we give you medications to help manufacture those blood cells themselves. Now, lowered blood counts are very closely related to immunity and infection, and it's worth spending a couple of slides talking about that because it is, again, a very important consequence of the treatment of myeloma, and we need to manage it effectively. A bit of a 101 biology for you guys in terms of your immunity. What makes up our immune system? It's a very, very complex tissue within the body. Whilst it is partly and importantly, the immune system does involve your white cells and your neutrophils and the clever parts of our immune system. That coat of armor that we all wear, your skin, the physical barriers, the hair, the nails, the chemical barriers that you have, such as the tears and the mucosal linings, are all part of our immunity as well. But I suppose most of us think about the white cells and the clever part of the immunity, which are these plasma cells and immunoglobulins and antibodies and the clever response our bodies put up if bugs come on board. And these can all be affected by myeloma and its treatment. The myeloma cells, as I mentioned, if we're normally and healthy plasma cells produce antibodies to help us fight infection. So it's commonly said actually that myeloma is a cancer of the immune system. So when you are producing unhealthy plasma cells and lots of this antibody, it's not working properly. And so that part of your immune system is not effective and is compromised. So when you have a lot of myeloma on board, your immunity is lowered. But also, and commonly, when we give you treatment to get on top of the myeloma, this further compromises your immunity because it can affect that physical barriers. So your soreness of your mouth due to tissue damage compromises your immunity. It's easy to get thrush, oral thrush and infections through the mouth. Also, if you do have a port or a pick or a Hickman line in, that's a break in the suit of armor that you wear, and that's a route of infection also. If you're required to have a surgical procedure or radiotherapy, that can further compromise the immune system. So we do need to focus on that as a consequence of treatment. Those that are particularly at risk of infection, in these times of COVID, we know that the elderly or frail are at particular risk of infections, and we need to take good care of them. And that's the same with patients who are being managed for a type of cancer, particularly a cancer that affects the immune system. But those with pre-existing medical conditions are also at extra risk, and those that have had lots of treatment in the past. Those with myeloma are at particular risk at particular times. And when we often talk about the winter flu season, one of the positive consequences of COVID is that the normal flu season is about 90% better because we're all paying great attention due to the COVID pandemic. But we do know that those people with myeloma who are living in a household, that family and friends that live in your bubble or your group also need to be keeping well and healthy so that you can reduce the risk for the person with myeloma living in that household as well. Those having active treatment for myeloma are at particular risk at particular time. So again, if you're on treatment, you're at higher risk than if you're actually not on treatment, when you're at a slightly lower risk of this. There are certain medications that put you at higher risk. I mentioned the lenalidomide or Revlimid and the pomalidomide. They're a risk factor, but also when you're taking a lot of steroids or you've taken steroids for a long period of time, they further lower your immune system. The chemotherapy that we use, cyclophosphamide and melphalan, also lower your immune system. And those having transplants or very intensive chemotherapy courses are also particularly at risk. I'm sure many of you are very seasonal cartoon there for you with Rudolph, but you know the signs and symptoms of infection. It's worth just reminding yourself of those, the temperatures that are above 38, if you have chills and fevers or hot and sweaty, all of these kind of symptoms are important to report to your doctor in a timely fashion. In terms of when you should seek medical advice, I can't reiterate this more strongly. If you are on treatment, particularly with high-dose steroids and lenalidomide and high-dose chemotherapy, if you do have symptoms of infection, you do need to seek attention that same day, okay? And there'll be various ways that you do that. You could do that via your GP or through contact with your treating team. Those that would be at lower risk are those with myeloma that is stable and you're not on treatment. And you would also just seek attention, but you may not require antibiotics. In terms of minimizing risk, then that's an example of those extra scripts we give you. We do commonly give prophylactic antibiotics, prophylactic antivirals to help prevent bacterial infections and viral infections. It's not uncommon to be on a Resprim or Bactrim. You may be aware of it under that name if you're taking lots of steroids and you're on that lenalidomide or pomalidomide drug. And certainly you need to take antiviral medication to prevent shingles if you are on bortezomib or carfilzomib. We commonly use the growth factor injections. We also can use infusions of immunoglobulins if your healthy immunoglobulins are very low. I can talk about that if anybody has a particular question. Vaccination is very important. Even though there is low amounts of flu outside of COVID in the community, you do need to still have your flu vaccinations and those in your household. And as and when a vaccine comes available for COVID, I'm sure we'll all be guided in that regard very, very quickly. Managing risks of infections are understanding the risks and the symptoms and how to seek advice. Make sure, particularly with those antimicrobials, you take the full course that is prescribed to you. You have your flu shots. And of course, with COVID, we're all very aware about the importance of hand hygiene, social distancing, etc., to minimize risk of infections. You guys and people with blood cancers have known about this for some time, and the wider community is only really realizing the importance of these strategies in terms of reducing infection. In terms of masks, again, be guided by the experts in Sydney. In Victoria, everybody's wearing masks. In Sydney, increasingly, we're required to wear masks as we go about in the community and certainly within the hospital setting. But in New Zealand, please be guided by the experts in your area. I couldn't do a talk without talking about, I came upon this great quote: a PET is a medication without side effects. Wouldn't it be great if we could all be prescribed a dog to treat our myeloma? And I know that's not possible, but many of us have 50% in Sydney have pets at home, can be a route of infection, but the positives outweigh the negatives. Really, the only advice around pets is to say, please don't be the one picking up pet waste or clearing out the cat litter if you're on treatment at risk of infection. This is Bonnie, who is our palliative care dog, actually at Royal Prince Alfred in Sydney. She's on the payroll at the hospital. We value pets so much, and that's my pet. That's Mushka, my dog, and she wanted to say hello as well. A pet is a medication without side effects. I would agree with that. So let's talk about peripheral neuropathy and steroid effects. Peripheral neuropathy, outside of infections and lowered counts, is probably the side effect that I spend a lot of my time talking to patients about. It is a significant side effect in myeloma because the drugs that we use to treat myeloma can cause toxicity to the nerves. So what do we mean about peripheral neuropathy? Neuropathy talks about any damage to nerves. So damage, inflammation, or degeneration of the peripheral nerves. What are the peripheral nerves? Well, the peripheral nerves are pretty much all the nerves in the body outside of the brain and the spinal cord. Okay, so when we talk about peripheral neuropathy, we talk about potential damage to nerves all over the body. But most commonly, we talk about damage to those nerves in the periphery, i.e. the ends, the hands and the feet is the most common symptoms of this peripheral neuropathy. And damage to those nerves leads to mixed messages from the nerves in the peripheries through to the messages that get through to the brain. It predominantly manifests itself as sensory neuropathy, which means changes in the way we feel things, but also it can be motor neuropathy or autonomic. Motor neuropathy talks about how the nerves impact our ability to function and move. So it could be muscle cramps or muscle weakness. And autonomic neuropathy talks about those nerves that manage the things that happen automatically, such as blood pressure. And we'll talk about what that might, how that might be experienced by a patient. Commonly, it starts in the fingertips and the toes, and that's why we often talk to you about, do you have any changes in the sensation in your fingers and toes? But the incidence and the severity, so how common it is and how severe it may be, is highly variable between different people, irrespective of what drugs that you have. So we know that myeloma itself can actually cause neuropathy. The myeloma protein can damage nerves in the body, and many people with myeloma, perhaps up to 20%, may have some changes in the sensations in their fingers and toes at diagnosis before we even give you the treatments. But most people with myeloma will experience a degree of neuropathy during the course of their disease, because the two common drugs we use, thalidomide, bortezomib, particularly, are known to cause nerve damage. There are some other factors that can cause neuropathy. Just aging, isn't that lovely to know, that can cause nerve damage. Those of you that may have diabetes can also commonly get nerve damage, and much of what we know about managed neuropathy comes from our diabetic friends and colleagues. Some other things, such as shingles, which is a viral infection, can cause terrible nerve damage and neuropathy, and a range of other vitamin deficiencies or autoimmune diseases can also contribute. So it's not just myeloma and its treatment. We use a fair bit of thalidomide, although there are other agents coming through that cause less neuropathy, and that can be mild in up to 50% of people with this drug, and moderate to severe in a fifth of people. It can be irreversible, so it's important to be monitoring for this as a symptom. With bortezomib, the incidence is slightly less, and it is generally reversible once we stop the drug. How do nerves get damaged with these drugs that we use for myeloma? We don't clearly know, but we suspect there are various parts. This is a nerve cell. It goes all the way from the spinal cord through to the end on the skin, and these cells can be very long. These drugs can, or the myeloma protein, can damage a variety of areas of this nerve cell, leading to the symptoms of neuropathy that you guys feel. I mentioned that the sensory symptoms are more common, so numbness, tingling, and pain in the fingers and toes are the most common symptoms, and that's why we often talk to you and ask you about these at every consult. But some of these motor and autonomic systems I mentioned can manifest themselves as muscle weakness. A common one there is something called proximal myopathy, which is where the muscles are weakened in the top of the legs, and you can find it difficult to actually stand up from a low chair. Muscle cramps can be part of that as well, and gait or coordination problems can be a symptom of that. The most common autonomic symptoms of neuropathy are what we call proximal hypertension, which is where when you go from lying to sitting to standing, if you do that too quickly, you can really feel quite dizzy. And that can be an effect of neuropathy. It can also be a blood pressure issue to do with your medication. So some of the things that people say to me and describe to me don't always fit into these boxes though. My feet are cold, but they're warm to touch. That's a change in sensation. That's a type of neuropathy. I can't do up the buttons. So manual dexterity can be a type of neuropathy. I feel dizzy when I stand up too quickly. Or this one I love, and it'd be surprised how many times people say this to me, that they feel like they're walking on cauliflowers or a cobbled street. A change in sensation, that is a neuropathy, and we need to know about it. A common way to assess for neuropathy is for us to be asking you questions, but I would suggest that also any change in sensation that you do report that to your doctor. There are some questionnaires that can help guide you in that, and there are some managing peripheral neuropathy booklets that you can access here that have these simple patient-reported questionnaires that, if you run through and answer that before you go into your consult, will help you translate those symptoms of neuropathy to your doctor and make it make more sense. We do sometimes do nerve conduction tests. We sometimes even do nerve biopsies and tilt tests and complex neurological assessments for neuropathy. But commonly, a conversation between your symptoms and your clinician is what we do at each consult. In terms of managing neuropathy, unfortunately, we do not have a treatment that we know is directed against repairing or protecting nerves. So key to managing neuropathy is assessing for it and managing any of those potentially reversible causes, such as unstable diabetes and vitamin deficiencies. But managing it is being aware of it very quickly and making dose adjustments or changes in the drugs that cause this in the first instance. In severe cases, we may have to actually stop the drug that's causing the neuropathy and think about changing you to something else. With the bortezomib or Velcade, we now give that subcutaneously, and we commonly give it once a week instead of twice a week. And that has reduced the risk of neuropathy by up to 1/3, which is a significant improvement. As I mentioned before, less can be more. Sometimes we need to reduce those doses in order to take the pressure off the side effects that they can give. In terms of active medications that we use to manage this, there's a range of particular drugs that are quite common. In our practice, we very commonly use Lyrica to manage neuropathic pain, but some other opioids or even some Panadol-based drugs can also be effective depending on how severe it is. We do sometimes also recommend TENS machines, nerve conduction machines, or even implantable devices, which can be used, and that would be under the guidance of a neurologist or a neurosurgeon, and I'm happy to take questions on that. Other strategies that can be very helpful, though, there's not a lot of hard data, but patients tell us about it all the time, are simple strategies such as exercise, massage, reflexology, even acupuncture has been found to be helpful in reducing the symptoms, particularly of sensory neuropathy. Wearing gloves and socks as a comfort measure, particularly when trying to sleep at night, can also be comforting to neuropathy. And many of my patients have found massage or circulation boosters, which help improve the circulation particularly in the feet, can also be helpful. Magnesium supplements such as Epsom salt baths and soaks can be useful as well, and various electrolyte supplements that you can get in sports drinks have also found to be useful to help with those cramps. I have included here for your reference a list of supplements that may be useful. This is anecdotal evidence from what patients are telling us. There's not many clinical trials that have reported on this, but you can find out more on the International Myeloma website, Foundation website, and the address is there for you. Some supplements may benefit or reduce the symptoms of neuropathy in some people. I'm going to just finish because I'm very aware that I want to give you time to ask some questions. And I do know that these slides will be available to you. You can re-listen to this if it's useful, and I'm very happy for you to have copies of my slides. But steroid-related side effects are quite broad, reaching, and can impact quality of life quite significantly. And you guys are going to be taking a lot of steroids in the management of your myeloma, so I wanted to just focus on those a little bit. We use steroids or corticosteroids, commonly the drug dexamethasone and prednisolone, in the management of myeloma. And many of my patients have been on courses of steroids for many, many years. They're very useful in twofold. One, steroids actively kill myeloma cells. When I first started working in myeloma, we used a lot more steroids because we didn't have this whole range of other drugs to use. They cause myeloma cells to die off. They also make the other drugs work more effectively. There is synergy between these drugs. They're certainly the backbone of treatment for myeloma, and they're not going anywhere, even with all these fancy new drugs. We also use steroids, though, to treat a range of symptoms, such as the very effective painkillers. They can prevent nausea and vomiting. They can reduce the swelling caused by a plasmacytoma, which is a lump of myeloma. And we also give them to manage hypersensitivity reactions as well. So we use a lot of steroids to treat myeloma. But they do have a wide range of side effects. Generally speaking, the higher the dose and the more you take, the worse the side effect may be, but that's not always the case. My patients always say to me, there are positive effects as well, Tracy. Don't forget to talk about the positive side effects. Steroids can help give you more energy, they can reduce pain, and they can improve appetite if that's a particular problem. But the side effects also of steroids are worth focusing on because they're not just physical side effects. These drugs can affect your mood and your behavior. And some quotes from some of my patients there that I'll leave you to read. I feel very discombobulated when I'm taking steroids. So these are the main side effects of steroids. They pretty much can affect every organ in the body, really. I mentioned mood and behavior. You can get very roidy on steroids. People talk about steroids being the devil's Tic Tacs. They can change your mood. They can make you quite high and quite low in mood, and high and quite low in energy. They can also cause some blurred vision and hasten cataracts. Certainly in terms of disturbed sleep is probably the most common effect of steroids, and that's why we suggest people take them in the morning. But they can have that energy high and low as well. They do impact the blood and immune system, and people on steroids are at increased risk of infection. They can also contribute to cramps and muscle weakness, and also affect your blood pressure. Steroids also can cause you to have fluid retention, and people taking steroids may notice that their ankles get puffy or they get puffy around the abdomen. They certainly can affect the tummy as well. When you take steroids, you must have them with food because they can cause heartburn and even ulcers in severe cases. People taking steroids for long periods of time may notice some change in their body hair, and that you can have more, particularly in women, you can get some extra facial hair, tends to be very, very fine, but also a thinning of the skin. So people can tear or damage their skin more easily when they've been taking steroids. And also we know that steroids can be hard to take if you're diabetic because they can increase the blood sugar level. So let's end on thinking about what we can do about some of these effects. We'll talk about mood and behavior first, because I think when people have lots of treatment for myeloma, they're often looking for the physical symptoms and side effects, and they don't appreciate that changes in the way they feel, their mood, feeling anxious or agitated, may actually not be them, but the drugs they're taking. And key to, if this happens in extreme cases, we do need to know about that because we need to reduce the dose of those steroids. Another example of less can be more. So hyperactivity and irritation can be commonly associated with these drugs, dexamethasone and prednisolone, more commonly on the days you take those drugs. We think it may be more problematic if you have a history of anxiety or depression, that these drugs can exacerbate that, but we're not really clear on that. We commonly dose reduce these steroids, particularly after a few cycles. Once we know the myeloma is coming under control, then we have room to reduce the dose of these drugs. Whilst steroids can cause, in rare instances, a psychosis, I have known it and seen it in the 20 or 30 years of my practice, that is very rare. The key to managing these changes in your moods and behavior is to understand the pattern of these changes, and keeping a symptom journal or diary, particularly for a few weeks or a few cycles, can be very helpful in managing or learning the pattern of all symptoms and side effects, that you can go back and reflect. And also when you see your doctor, you can go back and recall and remember how these drugs have affected you on any given day. And that's key to helping us understand cause and effect and how we may need to make some adjustments. Planning and pacing is key to managing these as well. Relaxation, mindfulness, and exercise. Exercise is such a good intervention to manage a whole range of side effects in myeloma, such as mood and anxiety, but also in terms of muscle weakness and cramping, energy, fatigue. Exercise within the limitations can be very helpful. And I do want to point out also, and I haven't mentioned it before, but of course, those loved ones and friends and family are impacted by these symptoms and side effects as well. And sometimes when it comes to mood and behavior, it's the loved ones that are going to appreciate these changes before you guys who are actually taking the steroids. So disturbed sleep probably happens in about 90% of people taking dexamethasone or steroids, and is very, very common. We do need to know about that, because we do need to help you with that, because sleep is very, very important for all of us. So do talk to your doctor if sleep is a problem. Sometimes we have to give you other drugs to help manage the sleep, but there are some strategies around that. We encourage people to take their steroids in the morning, but for some people there is a delayed effect, and that agitation and energy kicks in a little later. So for some people, they do find taking their steroids with some food at supper time is actually more helpful. Perhaps 10% of people that works for. Generally speaking though, you need to find what works for you. Most people take their steroids in the morning. In terms of sugars, if you do have unstable sugars or diabetes, please talk to your GP or a diabetes nurse about how to manage that. We do give slightly less doses of steroids, or we may need to increase the medication you take for your diabetes in terms of monitoring that. There's all sorts of information around sleep and sleep health, and I'm sure Leukaemia Blood Cancer New Zealand would be able to provide you with something like that, because it is an important factor for all of us in regard health. A couple more slides before we'll take some questions. I mentioned that these steroids can cause a range of musculoskeletal and immune problems as well. That proximal myopathy, or weakness in the legs, really can be a problem with long-term and high-dose steroids. So if you are finding a lot of weakness in your legs, do talk to your doctor. A key way of knowing that is if you find it's difficult to stand up from a chair, and that we may need to reduce those drugs as well. Most of you are taking a bone strengthening drug, Zometa or Pamidronate or Bonafos or something like that. So thinning of bones from long-term steroids is not so much of a problem in those with myeloma. Do remember to take your prophylactic antibiotics or antivirals, because steroids suppress the immune system. I've mentioned the importance of physical activity in terms of muscle strength, weakness, managing fatigue, and there are various strategies to help with that. I'm sure there are probably programs in your communities in helping you in terms of keeping physically active, and I can't reinforce the importance of that enough. Massage and magnesium we've spoken about in terms of peripheral neuropathy, also helpful for cramps that may be caused by steroids as well. Importance of signs and symptoms of infection are very well known to you, and we've mentioned those. So lastly, in terms of steroid effects, gastrointestinal, eyes, etc., please do take your steroids with some food, milk, a biscuit, or after a meal. I commonly tell my patients to take them with or after breakfast. It can cause heartburn. Another example of sometimes needing to take another supportive medication. We do recommend sometimes pantoprazole or Somac or a drug like that that helps prevent this when you're taking steroids. Blurred vision and cataracts can be hastened with a range of medications, not least steroids, and many of my patients have had cataract surgery, likely as a consequence of taking steroids. If you do have a high blood pressure, then make sure your GP or yourself is monitoring that, because steroids can increase blood pressure. And that fluid retention I mentioned, puffy legs, fluid around the abdomen when you're on steroids, keeping mobile, putting your legs up at rest, and keeping active is key to managing that. Some patients may need a diuretic, and some patients may need us to reduce that steroid dose, particularly the elderly and frail. So do talk to your GP and doctor if you're finding you're getting puffy and filling up with fluid as a consequence of these drugs. So in summary, because I want to give you time for some questions, do be aware of the medication that you are taking and the potential side effects of those medication. Report any of those to your GP or your treating team in a timely fashion. Let them worry about if it's significant or not. Just your role really is to survey for those effects and report them to the team. Early recognition and management is key to managing these side effects and keeping you well on drug, because key to managing myeloma is about allowing you to live well on therapy for myeloma. We commonly do dose reductions and scheduling changes. Less can be more. Consider a symptom journal. A lot of my patients keep a bit of a diary. Some of my guys will keep a very whiz-bang spreadsheet on all of these things, and it can be helpful when they're having conversations with us so that you can learn to pace, plan, and adapt around some of these side effects. Some websites there for you for further medication information on drugs and consequences of their drugs and how to manage side effects. And I'm going to leave you with some other resources. There's a wide range of information available from Leukemia and Blood Cancer New Zealand, as well as these myeloma specific international sites, including those in Australia and the US, that I would highly recommend. They have some particular information on neuropathy, myeloma, transplant, the immune system, etc. And I'll leave you with those. So I'd like to say thank you for listening. I hope there are some people out there. I don't know. I'm in my office talking to this screen. I'd be happy now to take some questions, Tim. Thank you.
Awesome, Tracy. Really appreciate you and your talk today. I think one of my favorite quotes today was, "A drug doesn't work. Drugs only work if you take them."
Yes.
That's my favorite quote for today. So I've got a few questions.
Yeah, please.
And I'll stop this. Here we go. So we can see us a little bit bigger. So first question was, what is the connection between Velcade and green tea?
Okay, so we don't really know, but I know you're probably alluding to the fact to avoid green tea when you are on Velcade. So green tea is a potent thought to be a potent toxic drug, and I've forgotten the language around that. Potent Tim, help me here. What's the word? Anyway, don't worry about the language. Okay, so it is thought that green tea and other supplements may actually protect the cancer cells from the effects of the treatment. We don't really understand the mechanism of that. In a similar way that we don't really understand the mechanism of why some antioxidant, thank you so much, Zoe Anderson, thank you, antioxidant might be a potent antioxidant and therefore have a protective effect on the cancer cell, and therefore the Velcade may stop the Velcade working effectively. We don't really know the science behind that, but there was a study in China, I believe, in patients with myeloma on Velcade, and in China they drink a lot of green tea, and what that resulted in was our general advice of not having lots of green tea within 24 hours of your cancer treatment in case it stops it working effectively. So that's the rule that we say. If you happen to have a cup of green tea once a day or something, we really don't think that's going to be a problem. But perhaps to be very safe, avoid it on the day you're having your Velcade injection.
Cool. Sweet. All right, I'm filtering through these questions. Our next question is myeloma considered a risk factor for worse outcomes if someone does get COVID?
Good question. So if you have any patient, any person who is old and frail, has pre-existing conditions, including cancer, including myeloma, particularly if they're on a lot of treatment, would have a compromised immune system. So you are not at increased risk of getting COVID, but if you get COVID, you would be at increased risk of getting sicker from it. you would be somebody that perhaps wouldn't put up an immune response. But saying that, none of us can put up an immune response because it's a new virus. So you're not at increased risk of getting it, but you may get sicker if you did get it. And that's why we're all trying to minimize the risk of this exposure within the wider community, particularly those that are older or have cancers.
Cool. Right, we've got 4 questions in the Q&A.
Yep.
And then I have 3 questions in the chat as well. So we'll go to the Q&A and answer those ones. So the first one is anecdotal comments from patients on the use of evening primrose oil.
Yes.
They split the capsules to release the oil for bortezomib injection site skin reactions.
Yeah, it is thought it's one of those things that cancer nurses do use or suggest patients use. There is a little bit of science behind it, and there were some nursing studies done, and they did find that it did not so much prevent local site reactions, but if you do happen to be one of those few people that has a bit of a bad reaction to the injection site, it may actually help minimize the symptoms of the itchiness or the rash or the redness to that site. So it is safe to use. It may work. And there were some studies to it. So yes, we do recommend that here in Sydney as well.
Cool. All right. Next question is, with peripheral neuropathy, do the nerves regrow, and will this only occur if the patient has stopped taking the particular drug?
Great question, Tim. So as I mentioned, the nerves can regrow, but it's not so much that the nerve has stopped growing or has been destroyed. It's been damaged. It may recover in time, yes, but they're very, very slow growing cells. So the key is to reduce the dose or stop the drug before the neuropathy gets worse. With Velcade, it is thought that in the majority of cases, the neuropathy or the symptoms of neuropathy will go back to baseline, i.e. if you had some pre-existing neuropathy before you started Velcade, it's not likely to get better than what it may have been, but it should improve. It can take 2 to 3 months to do that though. So yes, in the majority of cases, it will improve once the drug has stopped.
All right. That's really good. All right. Our next question is related to the one just before. Is peripheral neuropathy considered to be irreversible with lenalidomide as well?
So peripheral neuropathy, lenalidomide is not thought to cause directly nerve damage, but I certainly have lots of patients who have had lenalidomide who will describe to me that their neuropathy that they've had from other drugs may have got a little worse. So we do think it can agitate pre-existing neuropathy. Again, if you reduce the dose or stop it, if it is the drug that's causing it, then it should improve, yes. But it is rare if you've not had any treatment before with Velcade or thalidomide and just have lenalidomide, it's rare to actually get nerve damage from lenalidomide alone.
Next question is, I at 57 and have had 2 transplants over 13 years, the first 3 years ago. I live a normal life at the moment and am not having treatment other than regular blood tests. I'm very lucky, but my wife often worries about my immune system. Is it any lower than it would otherwise be? I know to be cautious anyway, but...
Yeah. Good question, and I don't really have an absolute black and white answer for you. I would say your immune system is certainly going to be stronger than most other people with myeloma. Absolutely. Whether it is as strong as somebody who hadn't had a transplant and doesn't have a pre-history of myeloma, we're not sure, because it's not just about the numbers. You might have normal white cells, normal lymphocytes, etc. But I would say your immune system is close to normal. But if you did get a nasty infection and you had to battle that, you may get sicker quicker because of your pre-existing health history. So I'd say you're pretty good, but not quite as good as if you hadn't gone through what you've been through. So listen to your wife.
I can vouch for that one. Just moving to the chat questions. Is it normal for me to have long-term fatigue 1 to 2 times each week, even though I have been in remission for 3 years?
Really, really good question. I think fatigue is probably the most commonly reported symptom. It's certainly in the top. Fatigue and peripheral neuropathy are the 2 most commonly reported symptoms in myeloma studies globally. Fatigue is probably the #1 symptom reported in any cancer study. Fatigue is also very common in the general population. Ongoing fatigue when treatment has finished and you're supposed to be well and supposed to be normal and getting on with life is also well reported. So thank you for bringing that up. It is common. In terms of managing it, it's also because it is caused by such a range of factors, not least psychological health, which we haven't even spoken about. What is coming out is psychological health is very important, but physical health is also important. And it's really hard during these times of COVID to do this. But if you can concentrate on a physical fitness regimen based on your abilities, and I don't know your history otherwise, that is coming out as probably the most effective intervention to manage fatigue. As well as if sleep is an issue contributing to fatigue, then we talk about the importance of sleep and sleep hygiene, and maybe I can find some resources and send them through to Tim, and the Leukemia and Blood Cancer colleagues will have some resources they can signpost to this group, because sleep and good sleep is important, and that impacts fatigue. But I'd say the other one to focus on is physical fitness, tolerance, and exercise. In cancer, it is just receiving a lot of funding and a lot of interest because it is so important in its impact, or positive impact on fatigue. But I do hear you. It's tough, it's hard to describe, and it's not a quick fix.
Awesome. We do have a webinar later on in our series on sleep. So.
Oh, fantastic. Great, Tim. That'll be great.
Awesome. Next question was spinal cord stimulation. Does this have good results for neuropathy?
So that's a good question. So spinal cord stimulation, which is the implantation of a device that will stimulate the nerves, it's usually in the lower back. It's undertaken by a neurosurgeon or under the auspices of a neurologist, is rarely required. And therefore we don't have a lot of data to say how effective it is. When it is required, obviously you've got pretty severe and ongoing neuropathy that's not improving over time, which is unfortunate. It can have a positive effect, and your team would not be recommending it if they didn't think it was going to have a positive effect. I probably only had 2 or 3 people I know under our care that have had this, and it's probably worked 2 out of the 3. So I think if it's had some improvement. I don't think it's a magic bullet, and nothing really is, but it has had a positive effect. So if it's been recommended for you, I would suggest you try it, because it shouldn't make things worse. The worst case scenario is it's a procedure you have to go under and it might not be that effective. But I think it's probably worth a go if it's been recommended. And as I said, I've got a couple of people who've had it, and 2 out of the 3, they've had good success. So best of luck with that.
A patient has internal shaking and trembling constantly. Is this due to the medication side effects?
Yeah. So good question. So there are, and I suppose, and hopefully it came out in this talk, that it's very hard to understand what drug is causing what effect, or is it you? What are you bringing to the mix? Is it the myeloma, or is it other health conditions, etc.? It can be hard to see the wood for the trees. Trembling and shakiness I would, if I had to pin it to the board, I'd put it under steroid side effects, but it certainly can be a type of neurotoxicity as well. So it could be, I would suggest you keep, if it's happening all of the time, then certainly talk to your doctor. It might mean that if you are on steroids, you need a reduction, or if you have been on neurotoxic drugs, the longer that you've stopped those, the better that would get. It can, of course, also be things not related to myeloma and not related to the drugs and do need looking into. But shakiness and trembliness are associated with the steroids. But I've not known these symptoms go on for a lengthy period of time. So if this person who's asked this question is finding shakiness and tremors that are enduring, they'd need to talk to their GP and their hematologist, because there could be some other factors associated with that, Tim.
Right. I've got one's a comment, but two more questions. Is that okay?
Yeah, fire away. Yeah.
All right. So first of all, someone said, "Thank you, Tracy. This was very useful. You had a little star above pressure salts." Oh, you, says you are. Additionally, so she's had low level of platelets recently and found a study that shows some type of magnesium might help, might reduce platelets, and just want to get your opinion on that.
Oh, I haven't read that study.
All right.
But what I suppose that comment, what it does tell us is, again, reinforces that there can be other reasons why platelets can be low. So, I mean, we recently had a patient who had what's called an Idiopathic Thrombocytopenia, which is just low platelets of unknown cause. And we thought it was the medication. It wasn't. There was something else going on there. I think if you were having, I mean, it's a good point in terms of taking magnesium or other over-the-counter supplements and herbs and things, is we don't often know what the consequences of that can be, particularly if people are taking very high doses. I hadn't appreciated that magnesium could cause low platelets, but I would hope they are not causing platelets to become significantly low, that they're causing ill health such as bleeding and bruising and things like that. But I can't answer the question directly because I wasn't aware of that association. A little bit of homework for me. Thank you.
Cool. I've got someone who's here and asked what your opinion of intravenous vitamin C would be.
Don't do it. That would be my opinion. It's not recommended. There isn't science behind it. And again, it would come under this, it's thought to be a powerful antioxidant. And that's why some people have thought powerful antioxidants would help protect you against cancers. But what we think, powerful antioxidants might actually protect your cancer against the treatment. So I'm not aware of any science, and by that I mean I work in medicine and nursing, and we adhere to evidence-based practice. So any robust clinical trials that support the use of intravenous vitamin C, and we would recommend our patients do not do it.
All right. We do have a vitamin C talk coming up in our webinar series, so our patients can tune into that as well.
Yeah, okay. So if there is some, and another example of the fact that I haven't read everything. So if there is some science around the use of intravenous vitamin C, then follow the advice of your doctors and your specialists. But what I do know, Tim, and I suppose what I was answering to then, is there has been a lot of people being charged a lot of money to be injected with vitamin C outside of any science, and you need to avoid doing that. So if there is some data around vitamin C, do it within the auspices of a structured research or with the supervision of your medical team as well. So good point. Thanks, Tim.
Perfect. Last question, and this person said, I understand water retention in the legs. I can identify when it happens, but did I hear correctly you saying abdominal water retention, and how would I identify that?
Yeah, so you can get fluid retention anywhere in the body. More commonly, it's in the lower limbs, ankles, because of because when you're walking about and you're standing upright, the fluid sort of falls to the bottom. But you can get extra fluid around the abdomen, and you can feel quite bloated, I suppose would be the symptom that you'd recognize. Now, you can be bloated for lots of reasons, such as, you know, having bowel disturbances or constipation and things like that. But you can actually feel quite bloated because you've got a lot of extra edema, and that edema or fluid retention can be anywhere. I wouldn't go looking for it. I think if you've got it, you'd know about it and you'd feel uncomfortable and you'd talk to your doctor. But most commonly when we talk about fluid edema, you have it in the lower limbs, and you can see it with puffy ankles, and if you put your thumb into it, it sort of often leaves an imprint. That can be caused by a range of conditions, not least underlying cardiac conditions, blood pressure, the heart, etc., not just the steroids. But with older people on steroids, we tend to use less steroids because of this risk of fluid collection in the lower limbs.
Awesome. Thank you, Tracy. We really appreciate you, I guess, sharing your time with us. I just wanted to share that a theme from the comments from the team as well as from our patients is that your presentation today was easy to understand, very understandable, and excellent delivery. So thank you so much for that, and we really appreciate your time and looking forward to the next time we can catch up again.
Thank you. Yeah, and hopefully we'll be able to come over and see you guys, because I do love your country. I think it's one of my top countries on the planet. You guys know that, you live there, but I do love coming to visit. So thanks for taking the time to listen today. You've got this on review, I know, but I'll be sending Tim my slides. If anybody wants them as a copy, I'm very happy for them to be shared amongst you all here.
All right. Stay safe, Tracy.
Thank you. Bye, everybody. Bye.